Welcome to Off the Chart with Medical Economics, a podcast featuring lively and informative conversations with healthcare experts, opinion leaders, and practicing physicians about the challenges facing doctors in medical practices today. I'm Jeff Bendix, Senior Editor of Medical Economics. My guest today is Matt Hollingsworth, co-founder of Carta Healthcare. Begun in 2017, Carta works with hospitals and other healthcare organizations to streamline clinical documentation and enable care improvement through analysis of patient data. He's here to talk about current and potential threats to the security of patient data posed by artificial intelligence and how we can guard against those threats. Welcome, Matt. Thanks very much for joining us.
Thanks for having me.
I'll start by asking you to sort of paint a picture of the current landscape of healthcare data and AI, and how the integration of artificial intelligence may produce new challenges or amplify existing ones.
So as a backstory to this, all of the patient data in the United States is protected by a regulation called HIPAA, which is a very strongly worded, very seriously taken legal framework around which you can share versus not share patient data. And effectively, the premise behind that is to make sure that people's sort of very personal health information doesn't get in the hands of people who might use it against them for one reason or another, either employment discrimination or back when pre-existing conditions were a thing, like insurance discrimination or any sort of thing that happens under that umbrella. And so the bottom line here that I want to, before we talk anything about the dangers and things like that, we don't really need a lot of extra new legal protections in order to protect people. We just need to enforce them in this new world of sort of new capabilities and the like. There's a very robust framework there already that as long as we adhere to the rules in it, everyone is going to remain safe. So that's really the key here. So the reason I'm sort of prefacing everything I'm going to say is that an important side effect of that is that we need to understand what these new capabilities are so we can understand how the existing legal framework could be violated if people aren't careful about it. Because as we'll see as we sort of move forward with the discussion, there's some not terribly obvious things that happen in the world of AI that can accidentally break things even if people aren't necessarily intending to do it. So that's sort of the backstory here. So I'm gonna talk almost exclusively about the provider's perspective on this because that's where I've been spending my time. And even more specifically about large providers, so like big hospital systems, health systems, things like that. Everything I'm prefacing it with that because everything I'm saying that doesn't necessarily apply to the sort of mom and pop primary care clinics or things like that. Some of the things I will say. But this is also where the bulk of the data lives inside of these very large health systems that are integrated across different specialties. So, okay, so that's all the background stuff. Now let's get into the details. So the way that it works today, there are these very large electronic health record systems that store most of the data, and the clinicians will document into that. And then there's this whole constellation of other supporting IT systems that often feed into the electronic health record systems, but are a separate source of information that are not necessarily 100% integrated into the EHR platform. So for instance, if you go and get a cath procedure, for instance, like to have some operation on your heart, there's a good chance that part of your data will live inside of this thing called a CVIS system, which is like for managing specifically cath labs and cardiology practices. So the main point here is that it's very fragmented, and it's very difficult to say, like, if you pass a regulation for an EHR, that won't necessarily impact everything because there's this whole constellation of other software systems that let the providers do their job that is not necessarily controlled by the EHR thing. So the reason I mentioned that is that there's this whole other framework of legal sort of regulation around what the EHRs have that will only protect a small percentage really of the whole ecosystem. So when we're thinking through all this, we need to not only come up with principles that apply to the EHRs, but also the constellation of software that surrounds it, that contains the patient data, again, within the four walls of the providers. So the reason all that matters is one of the things that is really interesting about some of the capabilities that AI sort of brings to the table, if appropriately applied, is making sense of all that data and trying to sort of turn it into one cohesive story about a patient, which can be a really powerful thing if it's applied appropriately. But a side effect of that is if you just pool all of the data that you have, like we have several hundred hospital systems. If we pooled all that data and used it to train AI, then there's leakage across all these really powerful blockades that happen with that around the four walls of the hospital that are very carefully designed to keep the data within those four walls. Because just let me use an example, like the large language models that we've heard a lot about from ChatGPT and that sort of thing. They basically they memorize all the data and spit it back out at you. So if you ask it, like if you ask it a question that's already been asked within the data, it's going to be very heavily biased toward basically just spitting out an actual patient's record, which is a HIPAA breach, just completely like without any question. That's why there are all these sort of copyright infringement or IP lawsuits that are going on right now in other domains, because it'll also very happy spit out a chapter of Harry Potter if you ask it to, or it'll very happily generate things that are very clearly copyright protected. Same exact story with HIPAA protection. If you've trained it with HIPAA data, it will very happily spit out HIPAA data back when asked. So the main point is that the extra layer of difficulty that AI adds to this conversation is that you need to know that it can do that and under what situations it can do that to protect against it. And these models are very opaque in the sense that not many people understand how they work. It's a very relatively, the list of people who can use it at this point is orders of magnitude larger than the list of people who understand these sort of how the sausage is made behind the scenes and what the risks are. That's where the danger lies. It's again not in the legal framework, not because again it is protected already, much more in the sort of understanding about how these new technological capabilities can accidentally poke a hole in the firewall of HIPAA.
Can you be a little bit more specific about the vulnerabilities that AI poses?
Yes. So, okay, let me take a step back here. At a very high level, there are two kinds of AI that are sort of worth discussing at this level of detail. There's supervised AI and unsupervised AI. Supervised AI is where you take an existing historical data set and train it up to try to replicate that historical data set with a new piece of data. So for instance, if you want to predict how long a patient is going to stay at a given hospital, that's a great fit for a supervised model. You look at all the patients ever and you say, well, if they're here for heart failure or they're here for diabetic neuropathy or whatever, like this is why they're here and this is how long they're going to stay at the hospital. So that's like that sort of mechanism is a really good fit for supervised learning. And the point there is that you use historical data to train the models. Unsupervised models don't require training. They're sort of algorithmically based, either like rule based, like if this then that, or there are much more complex versions of that are out there as well. But those don't need data to train. And you basically, like if you run it on a new data set, it doesn't modify the existing algorithm in the way that it's sort of configured and what it's capable of doing. Specifically the trained ones, which is by far the ones that people have heard the most about, are things that are trained on like the whole internet, like GPT, for instance, or ImageNet that's trained on tons and tons of labeled images. These sort of things are what the way they work is you feed it a whole bunch of data and it organizes it in this. There's a statistical framework that's called a neural network that it basically just reads through everything and memorizes it in the form of these, like it's a very large data set that when appropriately applied can predict what will, if you ask it, what is wrong with this patient, it'll look at that whole thing that it's memorized and then try to guess what's wrong with the patient based on the particular patient's data. And the key is that they take all this data in, they sort of suck it in, and then they spit out something that you ask them when you ask them. The key here, though, is that the way it's doing it is memorizing things. So if my data is in there and it says, okay, 36-year-old male, it has this and that medical history, and then I ask for a 36-year-old male with this and medical history, a very feasible outcome for that is that it just spits out my notes that it sort of ingested during the training process. Now, the reason that's a problem is if this thing was trained by sucking in data from lots and lots of different health systems, and say I was seen at Stanford, and then some other hospital asks, okay, 36-year-old male with this and this medical history, what's going to happen next, or when are they going to discharge or whatever, and then it starts spitting out text, there's a very high likelihood that it's going to spit out something that's actually my story. And so back to the HIPAA rules, there wasn't any that I didn't say, hey, you can transfer this data over there. I didn't say, hey, doctor, like, I want you to analyze my medical history. So the point is, the fact that my notes got spit out is a violation of HIPAA. So you have to be really careful that that doesn't happen. And that requires, again, people who know how to keep that from happening. But the key is that's where this breaks down. It's that these models are very large and they can memorize so much stuff that they can then regurgitate it in another form. And just to take this out of the healthcare setting for a second, Getty Images, for instance, has a lawsuit right now where basically it says, hey, I want an image that's, I think the one that was the one that stuck in my head from the lawsuit is a picture of some football game. So if you type in like, hey, I want an image of a football game, it actually spit out an image of the football game with the Getty Images watermark on it, because it had learned that, hey, there's a lot of like football games that Getty Images sells stock photos of. And so that it's not constrained to healthcare is my main point. Like it'll very happily do copyright infringement as well. And that's because fundamentally, like, without getting into too much technical detail, the right way to think about it is that these models are memorizing everything that's sent to them, like the internet or all the patient notes or like whatever it is that you're applying it to. They work by memorization, not by like coming up with some fundamental understanding of the data or whatever. It's just good old fashioned memorization and then spitting out something that looked very similar in its past. There's some interesting corollaries that I'll get into. Like, we're talking a lot about the sort of HIPAA violations and things like that, but there's this whole other branch of what happens when you have an algorithm that just memorizes everything that's happened and then acts like the next patient is like all the previous ones, which is kind of the opposite of what medical field is about. It's about exception handling, not about just treating every patient the same. But the one of the easiest like dangers to understand about this is the legal risk, which is just this fact that it memorizes data from one site and will very happily spit it out on the other is very clearly a HIPAA violation.
The data wouldn't have been anonymized before being fed into the AI?
So it depends on the use case. It is possible to do that, but it's hard for me to, these algorithms need a lot of data behind them. If you spent enough time anonymizing all of the clinical notes for such that you could train these algorithms, truly anonymizing them, I don't think there's enough money in our economy to do that. There are trillions of notes to truly anonymize things. And everyone thinks like, oh, anonymization is about like, if it says Matt Hollingsworth in the note, remove Matt Hollingsworth. No, it's a lot more complicated than that. And the reason for that is that, there's this, within the HIPAA regulations, there's this idea called safe harbor. Mm-hmm. It's very complicated, but let me summarize the salient point here, which is that data is only safe harbor if you've guaranteed that there is a large enough population of patients with the particular combination of medical complexity that's in, like, let's say it's a note that you're anonymizing. If in that note, it's like, this patient has this, and that, there needs to be a big enough population that you couldn't, with a second source of data, figure out, like, personally identify it. Like, so I have a daughter with a very rare heart condition. She has this thing called transposition of the great arteries. There are about 3,000 patients a year that have that in the US, give or take. And if you do out the math, you'll find out that, in any given state, it's obviously proportional to the state's population, but let's say that's roughly 100-ish that will be in a particular like region or a statistical region within from a census sense. So if you got one of my daughter's clinical notes, it says, first off, it's a daughter, and there are actually more males with this, so it even further shrinks the population. And then it's at Stanford, so it's sort of West Coast. If you got any other piece of information in the world, like this interview, for instance, and that note, then you know that note is about my daughter, because there isn't another option, basically. And so this principle behind it, so the only way that you can have truly safe harbor things that have any clinical interest whatsoever, and clinical interest meaning some like combination that is relatively rare. First off, you have to know if that, and so there's this whole work that for this note, We need to read through it carefully with clinical understanding to know, hey, how rare is this actually? And then when you find it, you have to exclude that data from the data set. And that's just really hard. The main point is if you truly wanted to anonymize the trillion notes that are out there, which is probably order of magnitude that, give or take, then, I mean, it's going to take order of magnitude probably $5 to $10 per note to do that. And so it's not going to happen. That's the point. Now, you can do an anonymization process for specific things, and there are these data sets that have done this, but for a very restricted set of patients. But they don't work for deep learning because the point of those data sets is to be able to do an anonymous query to say, like, how many people have TGA, for instance. Because the way that those anonymization techniques work is they do it at the query level, not at the data level.
Mm-hmm.
So they'll be like, hey, you can ask TGA, and then if it's too small of a data set, then we just won't let you run the query. And so you can solve it that way, and people have done it in that way. But the whole point is, like, if you remove all the clinical entry, like, interesting bits out of the notes, then what's the point in training a model for it anymore, right? So, like, not only is there not enough money to do it, but even if you did somehow have the money to do that, it wouldn't work from a perspective of just making it useful. So that's why it's so complicated. And there are cases where you can, like, if you have a collection of notes under one umbrella, like for a clinical trial, and you already have access to it, and you're not breaking any firewalls or anything by training only on that data set, it's a different topic. It's just, you have to be really careful about how you're doing it. And again, this stuff is new enough. Actually, it's been around forever, but like the application of it is new enough that there isn't a huge population of people who understand, like, when you can and can't do this, and when it's risky and when it's not, and all this sort of stuff. That's where it's the fact that this has become relatively recently truly applicable at scale and has a lot of interest behind it. That right this second in history we have this differential between interest and actual knowledge about how the thing works. That's where the danger lies. There's a big differential between what people want it to be and what it actually is, and that's always where the danger is going to lie here until there's a larger population of people who understand really well how this stuff works and what the dangers are.
Does AI pose? Can it be a weapon for hackers?
Yes, mostly on the social engineering route. Okay, so one corollary to this, it makes if you don't do this appropriately and the firewalls are broken, the sort of HIPAA firewalls are broken,
Mm-hmm.
because this memorizes things, then someone who understands how the model was trained could use it to just regurgitate a big chunk. Like, it wouldn't be 100% accurate, but if you really wanted to get at, like, a pretty high probability predictor of whether Matt Hollingsworth has some medical condition or whatever, and you get access to one of these models, then you could probably figure that out. If
Mm-hmm.
it's so that's one vector. I think really practically the biggest vector is going to be just effectively like a hacker productivity tool, not so much like new attack vectors. Like that is an example of a new attack vector, like getting access to one of these models that allows you to ask it questions with the relatively high probability predictor of success with it. That one's new, but I think the bigger sort of impact is not going to be on these new vectors, but rather just productivity tools for the old ones, specifically things like social engineering and phishing. And just because you can produce an order of magnitude more content in substantially less time and effort. So just if you think of them like businesses, like, the profit margin goes up because they can go and fleece more people per unit of labor. Mm-hmm. And again, that doesn't have anything to do with healthcare necessarily, just because the biggest risk for hacking generally is social engineering, like sending an email saying, hey, your boss just wants you to reset your password, like use this link and not type in your old password first, and then they have your password, and that sort of stuff. I think that's where the biggest risk lies.
But it's not. It doesn't provide new ways of breaching firewalls, for example.
Nah, anything recent, like the stuff that has happened has already happened. So yeah, none of the, or at least not to my knowledge. Like I don't know of any application for that currently, but that's not to say it wouldn't happen in the future.
So I guess the big question is then, how do we balance the benefits that AI so clearly brings with these possible risks to our health information?
That's a great question. The main thing is just accountability, holding people accountable for what they say it's going to do. And if they have a HIPAA breach, treat it like a HIPAA breach. Like, not, there's a lot of efforts to try to make like AI specific data protections along many different industries, not only healthcare. I think that's a waste of time. Like, this is it, just because you don't, if someone copies my note out of some deep learning model that they trained, they ought to be sued just like any other HIPAA breach. And if they did, they're not going to stay in business very long. And then other people are going to be really careful about it. Like, I think that's the way to handle it. I think our existing legal frameworks are, honestly, I think HIPAA's like, even, I'm not aware of any other regulation where if someone breaks in and steals your data, that you get sued, right? It's one of those, like, it's pretty harsh already. And for good reason. I think people should be very serious. Like, that gives you an extremely strong incentive to protect it. But the main point is, like, I don't know how you could be any more like, I don't know, severe, or like make new regulations that are even more harsh to protect people from it. Like, it's already extremely harsh. Like, there's stories of hospitals that like get their window smashed in and someone runs off with the computer and then they're sued for $1 million a record that was on that computer, or what have you. Like, that there isn't a much stronger punishment that you can get. So all we need to do is enforce it. Exactly. And so the key there, though, is we need to enforce it. Like, if someone, the second, like that Getty Images example, the second someone sees an example of them spitting out a patient, like one of these models spitting out a patient that didn't exist at that institution, whoever provided that API needs to be sued, either out of existence or, you know, in such a way that they regret their decisions, right? And the first time, that it's only going to take one time, and it won't take very long for that to happen. And so, like, the harm in that situation is that one patient got their record leaked, which I would never understate. Like, you know, that's a problem. Sure. But at the same time, I think that would be enough. And as long as if the justice system works even half as well as it has in previous HIPAA leaks, then justice will be served to the person who did that, and everyone will have a very strong disincentive to do that ever again. But the key is people need to be in the mindset to find these things, like, because again, this is a new thing. To put yourself in the seat of someone who would observe this, like the Getty Images example is an easy one to understand, because, like, imagine you ask it, hey, I want a picture of a football game, and it spits out something that says Getty Images, and you're like, huh, that's weird. Like, you know, you think like it's easy. Generating a patient note is like, it's just kind of harder to know that this was actually Matt's note or whatever, and, you know, and how do you define Matt's note and all this sort of stuff. So just people being informed about what to keep an eye out for in terms of this new class of HIPAA breach is, I think, the biggest sort of pull in the tent for enforcement on this. So fundamentally, it's an education problem about the existing legal frameworks and how these new tools can violate them.
It seems like you're saying that HIPAA in its current form could be enforced better than it has been. Is that correct?
Yes, for especially for these existing tools. Usually the way that these things work is that there will be a breach of some sort, like a ransomware attack or what have you, and then everyone piles on that. Like, there are these index events that, at least, I mean, I don't have an exhaustive list of all the ones that have happened, but at least the ones that make the news are usually of the form like, oh, this hacker did a ransomware attack and they didn't pay the ransom and they're releasing the records and now the hospital is going to be sued. Probably in terms of numerical number of times that HIPAA breaches have happened, that's probably not the biggest. Probably more accidental things that are, you know, people just kind of don't think about and no one ever finds out about. Yeah. This is going to be under that umbrella. And part of the reason why it's not enforced is because they're much smaller harm events. Like, if someone accidentally, like, technically it'd be a HIPAA breach if you printed out a patient's record, you left it on the desk, and like the janitor picked it up and threw it away. HIPAA breach, technically, but, you know, is that worth their time to enforce? And it's, you know, there are bigger fish to fry generally. But for this one, the difference is that one is not a systematic failure, right? That's like someone made a mistake and left the wrong paper out on their desk. Mm-hmm. These algorithms, if they're going to keep doing it over and over again, they take the form of those single event sort of mistakes, like the leaving out a piece of paper on a desk. But the problem is they're going to be happening at a very wide scale. So it sort of ratchets up the importance of it, because you're only going to see, 1 out of 100 that it's doing, but you need to jump on that even though it's a small event, because it's not actually a small event. Like, it's generating lots of them, and it's the same algorithm doing it over and over again. So that's the failure. And just to sort of talk about the reason this matters is we want companies like ours to be incentivized to not make the mistakes that would cause these things to happen. Like, I know this very well because I've spent my whole career doing it. And so, like, it's impossible that data leaks across in our particular setup because we never send the data to a central location. And we have that as a core tenet of doing it. It always hangs out within the four walls of the health systems that we work with and never leaves. So what we use publicly available data sets to train a baseline model and then fine tune it at each of the sites using their data, but their data never leaves, and the model fine tuning never leaves either. So it hangs out in their institutions. That's a technique that can work in our particular space, but some applications of AI are going to need full data. And from my experience, it's too hard to do that in a way that is not likely to do a HIPAA breach. So I just didn't create a company that did that because I'm not willing to fight that fight. But if someone goes out there and builds a company to do it, they need to realize that they are fighting that fight, and it is an important fight. And if they don't fight it just because they want to raise capital faster and grow faster, and they create a bunch of harm, then they need to be punished for it. So it's more of people need to be aware what to look for and make sure that they hold people accountable that are fast and loose with the rules, so that people aren't fast and loose with the rules in the future. Because as soon as one company gets blown up from a HIPAA lawsuit for some deep learning net that they trained, then there aren't going to be many after that are going to make that mistake.
You see any emerging threats over the horizon? Things that we just haven't really considered yet?
Yes, there's a more nebulous threat that is, I want to give the sort of form that it will take, but I don't know the specifics of how this will happen. So AI is not magic, it's a tool. It's just like anything else. It's just like a hammer. You can use a hammer to build a house, or you can use a hammer to whack people over the head. And since caveman days, we've learned that whacking people with a hammer is not a productive thing for society. And so we have laws against hitting people with hammers. That's it. That doesn't make the hammer evil. It just means that you don't hit people with it, and then you can build things, and that's awesome. It's a great tool. Same story with AI. You can use it. You can, for instance, consistently use it to help people document their patients better. That's what we do. And there's we know how to do that in a way that's not dangerous. But if you use that same exact technology that we built to diagnose patients, then you're going to screw stuff up. People are going to get hurt, and they're going to get a diagnosis that doesn't correlate with what they actually have, and they're going to be worse off than they were beforehand. And so if you aren't careful, and if someone goes out there and pitches, hey, I've got this new idea, and I'm going to use this AI algorithm to diagnose patients so that we need less doctor time because we have a doctor shortage, and blah, blah, blah. And then they go raise $1 billion. And then they just do a bunch of harm because they can't do that. And no one sat down and asked, hey, does this thing actually work? So I think that's going to be repeated consistently. And this isn't a new thing. Again, GPT was not the beginning of AI. I've been doing this for a better part of 2 decades now. And there have been at least 3 other hype cycles along the way.
The scenario you just described sounds a lot like Theranos.
That sounds a lot like Theranos. And I'll guarantee someone is going to try to pitch that. And we as a society just need to stop it from happening, because, and the way you do that is you just hold people accountable. Again, if you say it does this, it better do it. Don't, and check it early. For us, the way we do business is we have a risk-bearing contract, for instance, where what we say is, hey, you're going to need less nursing labor to fill out these forms, and so we'll charge you per form less than you were paying before. And if the AI doesn't work, well, we're left holding the bag, and that's great. There are many alternatives where the technology provider can bear the risk. And I would be extremely leery of anyone who is selling AI solutions where they are not bearing the risk of the engagement. And that decision criteria by itself is almost enough, to protect against that sort of thing. But historically, what people do is they'll be like, hey, here's a SaaS contract, and your board wants to be AI, so we'll AI you for $5 million a year, and then nothing comes out of it, and and then the company like makes a bunch of money and kind of doesn't really care. Like that class of failure is, I think, going to be pretty significant over the next let's say 5 to 6 years while we sort of work through this particular crazy hype cycle of over promising and under delivering, which just keeps happening. Thankfully, though, because this is like the third or fourth one, depending on how you want to count it, that have hit within the last couple of decades, hit big provider systems, they're extremely leery of it, which I think is a great thing for helping us prevent those sort of that class of failure. But anyway, the main point is this is a like, okay, we need to come off of our cloud and figure out what this actually is going to do for us sort of thing. That as long as people keep in that mindset, I think we can protect ourselves against it. But we haven't historically been that great at that. So that's why it's a big concern for me.
Well, that seems like a good note to end on. Thanks very much, Matt. This has been very useful, and I think our audience will be able to use a lot of what you've said here.
Awesome. Well, thanks for having me.
Thanks again, Matt Hollingsworth.
Thanks for listening. You can subscribe to our podcasts on Apple Podcasts, Google Podcasts, Stitcher, and Spotify. And when you do, please leave a review. You can find previous podcast episodes on our website, medicaleconomics.com, under the Media tab. We welcome your comments and suggestions for future podcast topics. You can email these to us at medec@mjhlifesciences.com. And while visiting our website, be sure to check out the latest news about the business of healthcare and explore the many other resources you'll find there. We hope you'll listen next month for a new episode of Off the Chart with Medical Economics.